All right, so for our final speaker today, we are really lucky and in for a treat. We have Dr. Gil Wernovsky, who's going to present on Norwoods, which of course, and hypoplastic left heart syndrome, which is all near and dear to our pediatric hearts. But we're looking at a giant, and we are very lucky to have him today. So thank you for joining us.
Thank you, Justin. I realize that I am the last person between you and the party and the beverages. So Richard, I'd like to thank you very much for this spot. And I'm going to try to put a clinical bookend on all the technology I've heard about today, which has just been absolutely fantastic. I have no disclosures. You've all seen these cartoons of a Norwood operation, and I'll tell you why I'm up here in just a second. It always looks so clean, you know, and whatnot. But I think especially for people that have maybe online or don't do pediatrics or haven't really seen what the field looks like, what the operative field like. This is the ascending aorta of a child with aortic atresia, hypoplastic left heart syndrome, and it's about the size of the suture. And I'm always amazed at the work that the surgeons can do and all these kids and young adults that I now take care of. And in particular, the work that the surgeons do together with the perfusionists. But creative ways had to be devised for cardioplegia in these kids. It's a special cardioplegia needle tubing for 2 millimeter ascending aorta. And then what was described to me connecting the ascending aorta to the main pulmonary artery here, these fine sutures. If you don't get that triangle right, you don't come off bypass. That is the whole operation right there. And then it always, you know, it looks good at the end, but, you know, it never looks as pretty as in these pictures. And it's important for me to put that up there to put some realism on what I'm going to speak about for the next 20 minutes or so. We think of this as a series of staged reconstructions as though it always has been this way. I've been in practice about 40 years, and I can guarantee you it hasn't been as clean as this. And for some of you who've started relatively recently, I hope to share with you some of the bumps in the road that have happened and where we are right now. So I'll start with my own personal journey through this and some observations, some patients who have shared their story with all of us. How are the kids doing? A slightly different way of approaching this and when we're going to do the Norwood operation and some proposals for next steps. So just a little bit of history. The most important thing from a medical cardiologist, I'm a pediatric cardiac intensivist. The most important thing for me in the history of all this is what we all take for granted now, which was the approval of prostaglandin in 1980. So if you were born before 1980 with any of these duct-dependent diseases, you did not survive. And that's why there's nobody old enough yet to be in their 40s or 50s. And really in their 30s is when we started getting good. And then there was a flurry of stuff. The Norwood operation, neonatal heart transplantation, and interim bidirectional Glenn, which I'll share with you in a second, the fenestration of the Fontan, ABO incompatible heart transplants. A lot of this stuff happened back here. There really hasn't been a disruptive event in the treatment of these kids for about 25 years. And probably the last major thing that happened in the field was the single ventricle reconstruction trial, which was comparing a Blalock-Taussig Thomas shunt to a Sano operation. And I'll talk about that in just a little bit. In Japan, since about 2012, they've been deferring the Norwood, and we've modified that at Children's National in Washington, D.C., which I'll share with you as well. If you haven't seen this, I found this fascinating. In 1970, a general pediatrician proposed the first operation for hypoplastic left heart syndrome. And that was George Miller. Glenn Kaler was a surgeon, and they used what they had at the time, a septostomy, pulmonary artery bands, and a Waterston shunt. And this was the first in-press therapeutic approach to hypoplastic left heart syndrome, which looks very similar to the hybrid approach that we use today. Fascinating to see. None of the patients survived, but it was pretty interesting. 1970. Here's 1977. If you haven't seen this, this is a paper that would never be published in 2025. I guarantee it. A couple of things that they said. Dr. Doty and the team talked about a functionally normal circulation. They did an atrial septectomy. They baffled the pulmonary veins to the tricuspid valve, and they put a conduit in from the proximal pulmonary artery into the arch. And then they did a second Dacron conduit. So basically they did a Norwood and a Fontan in a 5-day-old. They did 5 of these operations that they published in 1977. All of the patients died. Now, I don't know if I would see a paper in 2025 that started out in the conclusion that none of our patients survived. But what I loved about the conclusion was it was experienced to present and to stimulate thought for some hope for some babies. And that was 48 years ago, I would say. I should have sound here. Could you?
Half a heart. Without medical intervention,
I'm just going to start again. This girl's name is Megan.
Megan Adams Roswick was born with half a heart. Without medical intervention, the condition is 100% fatal.
Also had a baby born with
Anybody old enough to remember these shows of the 700 Club?
100% chance of death. Give him no chance to live, but here is a phenomenal story.
Is a matter of life or death for some. At least it was for Megan Roswick.
Who said that this is the single worst defect that a child can be born with?
If you imagine that this truly is just abnormal plumbing, then we've got a structural problem, and structural problems lend themselves to structural solutions, reorganizing the plumber. So the people that reorganize structure generally are surgeons.
And then, of course, Bill did fantastic stuff. It was tough because he did not have that enthusiastic following by the cardiologists, to put it mildly, for that thing about the hypoplasty. And it was tough, and he fought it through. And he had different, there were different approaches. Initially, that didn't work out and so on, but finally he succeeded.
That's Dr. Castaneda, who was the first surgeon I had the privilege of working with, and I liked how he said it was not thought well by the pediatric cardiologists, to put it mildly. This was in the age of putting babies with hypoplastic left heart syndrome in a corner and letting them pass away. That's not that long ago. So prostaglandin was approved in 1981. That's when we started trying something for these babies. This is Stephen Klein. Stephen was the case report. Stephen was the first child who survived, first a Norwood and then a Fontana operation, and it was reported when he was 3 days of age by Bill Norwood, Peter Lang, and Dolly Hansen. And he was very proud of the fact that he was the first survivor. He would talk about it quite a bit. He passed away from an arrhythmia in his 20s. He wrote a chapter for our book. It was just fascinating to have the perspective of someone who knows there's no one older than him with what he has on the planet. And it's interesting to think that our parents of our patients and our patients think that as well. Peter Lang was my mentor. I still stay in touch with him. He lives up in Massachusetts. And, we take for granted that we understand how the blood goes around in a baby with one ventricle, but it was this group and anesthesiologist Dolly Hansen who basically anesthetized all of these patients that had hypoplastic left heart syndrome. And I believe Dave Farrell was probably the perfusionist at Boston Children's for all of these as well at the time. If you haven't seen it, topical cooling was a little bit differently, done a little differently back then. There is a baby in there, and then they would get over to the operating room table. Let's see if this one comes.
Good evening, everyone. A 14-day-old baby girl is fighting for her life tonight after receiving the heart of an infant baboon.
It has never been done before, not successfully, and not on a patient so small.
Doctors praised the so far successful transplanting of a baboon heart into the body of a baby girl who was certain to die.
My options that were given to me were, you can leave her here and let her die, you can take her to Barstow Hospital and let her die, or you can take her home and let her die.
I became deeply impressed with the fact that we've seen a number of babies with incurable heart disease, incorrectable heart disease, babies in whom you could only experiment surgically with. And it impressed me that what those babies needed really was heart replacement.
I think Baby Faye's legacy has to do with the hundreds of babies that are now alive who would not be on our planet without her experience.
I remember when this happened, I was a second-year pediatric resident, and I was like, I want to do that. That sounds really like they're putting baboon hearts in people. What a crazy, crazy field that is, that pediatric cardiac surgery. I found a couple of things. The internet's great. I Google searched a lot of this sort of stuff. So this is something on the cover of the New York Times. And it said, baby with baboon heart better, surgeons defend the experiment. So it's called an experiment in the New York Times. These were the animal rights protesters outside protesting the life of the baboon. The staggering cost of a baby Faye, wishful thinking. And can you imagine if social media was around when this was done, how within a week there would be an incredible amount of outrage and two sides would have been brought up. And there was a bunch of that. There was a lot of things that went on in the scientific meetings, but it was a very different way of debating right and wrong and whatnot. I'm not going to get into politics, but we live in a very different time. And to be able to see a paper like this, 1985, which is when I started my fellowship, he first reported this, and then he reported the model of heart transplantation. It reminded me of Dr. Doty's quote, which said, although this experience was with a subhuman primate, baboon donor, source of donor graft makes little difference with regards to the technical aspects. And this is how a lot of the refinement was done on the arches. There was no simulation. This was Dr. Norwood, Dr. Castaneda, Dr. Bailey working hard at a lethal disease, basically. And then he published his first case with a baby. It was called Baby Moses. Baby Moses is now 40 years old, was the first infant who had an infant heart transplant. And the saga continues. There was a time now where there was a debate at every AATS and every American Heart Association of Bill Norwood and Len Bailey talking about whether transplantation or a Norwood operation was the best way to go. And there was always a third person who would say, we shouldn't be doing this. This is crazy. It was wild times. It really was. This was the first reunion that I went to of some of Dr. Norwood's patients, and there's 51 patients there, 51 ventricles. And if you'll notice there are very few old kids. It wasn't until the 90s that we started to get good as a field at doing this, and that's from perfusion's perspective, surgery's perspective, anesthesia, ICU nursing, et cetera. And here's a few of the transplanted patients with Dr. Bailey. Oops, sorry, wrong way. Arthur C. Clarke said that every revolutionary idea seems to evoke 3 stages of reaction. Number 1 is it's completely impossible. Second is it's possible, but it's not worth doing. And then I said it was a good idea all along. And that's where we are now. But I can tell you at the time, this was a very controversial way to approach this. So I started my fellowship at Children's Hospital in Boston. I spent 10 years in Boston and 18 years at Children's Hospital Philadelphia. And during about the first 22, 25 years, most of the neonatal surgery was being done at those 2 institutions. And I was lucky enough to be at the right place. Someone took this picture of me. It was a parent of this baby that took this picture at the bedside when I was a first-year fellow. We all wore these white scrubs and everything. And that was a little boy named Jesse Van Sickle. And he was one of the first patients I ever took care of as a young first-year fellow. He also passed away from an arrhythmia at about 29 years of age. At the same time, same month, during my first rotation, when I decided I wanted to do this for a career, this kid named Chris had his Fontan. Now, at that time, the Norwood staging was 2 procedures. You had a Norwood operation, and then you waited about 2 years, and then you had a Fontan operation. 1 in 4 babies died during the Fontan. Now it's about 2%. Effusions kept kids in the hospital. It's a very different time. Chris grew up and has done very, very well. I told him that I was going to be doing this picture. This presentation. He sent me this. He's quite tatted up. He was getting his pacemaker revised here, and he says that was the smallest. He told me to say it was the smallest fish he caught that day. But he's 42 years, hypoplastic left heart syndrome, and he's living a good life. And I am so lucky to have worked with these 3 surgeons: Dr. Spray on the left, Dr. Castaneda in the middle, Dr. Norwood on the right. And it was Dr. Castaneda who told me when I would go into the operating room, go sit by the pump. You will learn the most in the operating room, not by watching me put in stitches, but by sitting behind me and seeing how we go on and off bypass. And it was some of the best advice as an intensivist that I got, and I bring all of my students there as well. The team in Philadelphia, Dr. Norwood, John Murphy, Susan Nicholson, are shown here. And I'm going to show you the experience from Philadelphia now. You could see here in the 89 to 92 range, about 100 Norwood operations were done per year. So that's about 2 per week, with half of them dying. This is the struggles that we had in the intensive care unit. That's the number there. That was the cumulative mortality risk. As you can see here, we could draw the lines. And I'll point this out, that none of the cardiologists who worked in the unit at that time chose cardiac intensive care. The nursing turnover was impossible to sort of deal with. It was tough. It was a really tough time, where every week you would lose a baby with a Norwood, and every other week you would lose a baby with a Fontan after a Norwood. Now, 1990, things started to flip around. And I think the biggest thing that happened to the Norwood procedure was the introduction of the bidirectional Glenn. Now, we know the bidirectional Glenn takes the volume load off and it's good for the ventricle. Why would that help the Norwood? Well, the most important thing was it allowed to put a smaller shunt in. So once the Glenn came around and the surgeon knew that he only had to, or she only had to put in a shunt for 6 months, that changed everything. We now had kids that were coming into the ICU that were more stable, and the surgical survival went way up. And it was nothing to do with the technique of the Norwood, or nothing to do with the smarts of the intensive care unit. It was because the shunt was smaller. So the Glenn really helped in that way. This is a guy named Tom. His last name is Glenn. Tom is now a pediatric cardiologist with hypoplastic left heart syndrome. He's one of my patients. I've taken care of him for 20-something years. And he went to medical school, and he decided to become a pediatric cardiologist. When he was a medical student, I brought him in on the left here to the OR for a photo. I had to do this photo up, to be honest. He scrubbed in, and it was the first, this is with Redmond Burke at Nicholas Children's Hospital. Jorge Ojito, some of you may know, was the perfusionist for this case. It was the first time somebody with a Norwood scrubbed in on a Norwood. So this is a very historical photo that you're seeing here, and shows you how far we've come from letting my baby go home and die. Here's audio here.
And everybody else out in DC right now. My name's Tom Glenn. I'm a 32-year-old living with single ventricle heart disease. My last surgery was 27 years ago. It was a Fontan operation that I had out in Philadelphia. Ever since that operation, I've been extremely lucky, and I live a pretty normal life. I'm currently finishing up my pediatric cardiology fellowship out here in beautiful San Diego, and I'll actually be moving to Michigan here in a couple months to start a 4th-year fellowship in advanced Fontan care. I love sports. I hike a lot. I love exploring national parks, and I'm getting married in a few weeks. So I'd say my quality of life is pretty darn good, the same as anybody else, I feel. I have a very strong interest in mental health outcomes for individuals living with congenital heart disease, specifically children. And I'm actually working with Gil on a project where we're looking at resiliency for children with congenital heart disease. I'm involved with a newly formed Fontan Outcomes Network, which is the learning network here in the United States that's aimed at improving long-term outcomes for individuals with Fontan circulation like myself. So thanks for all your interest and everything you guys do. It was nice meeting you. Bye.
I can't tell you what it's like to sort of see that. There has been no feeling that I've had better than writing a paper with one of my patients. It has been an unbelievable journey for me to go through all of this. And all of you who do such incredible work in the operating room, I unfortunately don't get a chance to see this stuff at the end. And what it's like is so important for what we all do. How are we doing on time? Okay, good, thanks. Okay, so here we are. I showed you this graph before. A lot of people have analyzed this data to try to figure out how can we get better. In this era, in Philadelphia, we were using deep hypothermic circulatory arrest. Delayed sternal closure was rare. Fresh whole blood in the prime. Routine staging, which we talked about. Somewhere around 94, we started using milrinone on the pump. Somewhere around 96, we were using modified ultrafiltration all the time. And then is when the randomized trial came out, which I'll talk to you about in just a second. In the ICU, what was going on at the time? There are a lot of things that were constant, but prior to about 1995, we thought it was all having to do with the ventilator. We talked a lot about balancing flows and this and that and the other thing and avoiding oxygen. Tom Spray said this to me one day. He goes, don't worry about the PVR. The best way to limit pulmonary blood flow is with a tube of Gore-Tex. And I'll always remember that, because once you put the tube in there, it doesn't really matter what you do downstream in the lungs. If you restrict it with a tube, you're okay. But you want to make the heart work well. So we started working more on lowering systemic vascular resistance through the many strategies many of you have probably been involved with. We then moved to try to get the kids extubated relatively quickly. And as the data supporting what we do in the ICU now is all anecdotal, it's all sharing best practices, but there's not a lot of randomized work that's been done to show what is the best. When we looked at the CHOP experience over 23 years, 8 surgeons, at that time 1,300 Norwood procedures, we couldn't find an association with who the surgeon was. But what about the rest of the team? That's rarely mentioned, right? People always, the name attached to the case is usually the surgeon. But what about who's the anesthesiologist? Do you have a different perfusionist every day or a consistent perfusionist? The same scrub team. What about the care model? At the beginning of this, and I remember these days well, the fellows who were generally second-year general surgery residents in the ICU at CHOP were providing care for these fragile babies, and the surgeons were dictating that care from home, not sleeping at night, and then getting up 2 days later and trying to do another Norwood. At CHOP, a new pediatric cardiac ICU director, which was me, and we built a new unit, and as soon as we got there, we limited the number of physicians. There was another director. Every time we make a change like this, for the new director, we change in-house call, the mortality goes up. Every single time. You get a new surgeon, mortality goes up. You get a new ICU director, mortality goes up. You move into a new unit, mortality goes up. And you have to sort of I don't know if there's similar stuff that you see in the OR. It wouldn't surprise me if there were very similar things. Again, back in the 80s and 90s, most diagnoses were after the kids were born. They were in a NICU and then they went to a PICU. Then prenatal diagnoses came. We started to have them born closer to the surgical center. We moved to a new cardiac intensive care unit. There were in-house deliveries, new CICU director. All of these things, you can't put these into a multivariable analysis. These are things that happen in your system, but you can't really plug it into your analysis. I know they're important. I just can't tell you how important they are. I'm going to spend just a few slides talking about the SVR trial, or the single ventricle reconstruction trial. Anybody familiar with that, or anybody participate in that? A few people. All right, I'll share that with you. One thing that I don't think most people know is the original name of that trial was the VISIONS trial. It was a much better acronym. It stood for Ventricular versus Innominate Shunt Impact on Norwood Survival. I loved that, but the Pediatric Heart Network did not. Originally, we were doing it just with these 4 centers. It then was funded by the Pediatric Heart Network. And between May of 2005 and July of 2008, so 20 years ago is when this started, 555 kids were enrolled, half of whom got a BTT shunt, and the other half got a Sano shunt. To cut right to it, in the first year of life, the Sano, which is on the top, or the RV to PA conduit, had a survival advantage in the first year of life. That's a hazard curve. You could look at it basically, that's when it made a difference, in that first year. And then someone pointed out to me recently that of the 14 centers in the original trial, only 1 had an interstage monitoring program. Now, if you don't know what that is, there's a way of looking at these kids after hospital discharge with daily or 3 times a week contact with a nurse and weights and a whole bunch of other things that have been shown to reduce interstage mortality from 10% to about 2 to 3%. It's been a really big thing. It didn't exist in this trial. So if it did exist in this trial, I wonder whether we would have had the same result, and I wonder whether we would all still be doing BTT shunts. You never know when things change during the trial that are system-wide that you can't put into a multivariable equation. I think I have 5 minutes left, so I'm going to go very quickly with these last few things. There's no difference now by the time kids have become teenagers in terms of transplant-free survival with either one of the shunts. in terms of right ventricular ejection fraction. The Sano group has a higher incidence of protein-losing enteropathy and catheter intervention. So the key part here is there's a cohort of 555 kids now that I think it's down to about 300 now that we're following as we move along. And then I'll skip the neurodevelopmental stuff. I'm speaking about that on Friday. So how are we doing?
At least it was for Megan Roswick. He said that this is the single worst defect that a child can be born with.
Did the Roswicks make the right decision? There would be 3 operations in 2 years. But would Megan's quality of life be good after all that surgery? Will she have anything like a normal life?
Her body will tell her what she can do and can't do. That's what they've always told.
That was Megan's dad. So here's the data. This is where we stand today with results of the Norwood operation. So if we take 100 babies that are born with this now, we can basically say from all the data out there that roughly 1/3 of them will not make it to elementary school. Of the ones that survive to high school, about 60% will have neurodevelopmental challenges, not terrible, but will have some issues that need additional help, and about 10% will need to be transplanted. So we can say that if you're born with this disease currently, the optimal outcome is between 15 and 20%. And a good outcome in 15 to 20% as well. This is historically an amazing result, right? A lot of morbidities in the intensive care unit, as you can see there, as you can see with the hybrid here. So I'm not satisfied, to be honest with you, and nothing has happened much in the last 15 years or so with this operation. It's time to change something, and we don't like to change things as a field, to be perfectly honestly with you. To be sure I get to the end, I'll just again say that we've had no new disruptive ideas in the last 15 years. And the approach we're taking in Children's National now, following a little bit from the approach in Japan, is we know that if we operate on this baby, the heart's not good, the gut's not good, the brain is developing, the kidneys are immature. But we're still doing the Norwood operation, which is a big stressful operation, and you come out of it with exactly the same physiology. So what can we do? How do we make the baby's brain develop better rather than putting that baby on bypass at a few days of age? We can do better than this. So after the neonatal period, we have this. We know all of these things happen. Heart's better, mom's better, all the other organ systems are better. So what we're doing in Washington now is we put pulmonary artery bands on at about 2 days of age and immediately improve systemic perfusion and get some good angiogenesis and myocardial performance. We put that baby in mom's arms for a month, let them feed, and do their Norwood at a month. And stay tuned for that, but it seems to be working. It seems to be moving those 2 risk periods, the transitional circulation and the Norwood operation. By doing all of those things, we're pushing that risk over here. We've had many kids go home on PO feeds. We've lost 1 out of the last 15. It seems to be working. And then I want to show you one thing about Meg. Meg is that little girl, the last video that I showed. She's a pistol. She has done a lot of things. She jumped out of a plane, as you can see there, got HLHS on her hands. She snowboards. She does all the things I told her not to do, which shows great intelligence on her side. She tattooed epinephrine on the back of her neck. She's really just a great person, as you can see here.
My purple.
You're not purple. You're a nice hue of purple.
I'm a nice hue of purple.
You want to say something, Karen?
Okay, my legs are hurting. It's not really my heart right now. It's my leg.
So she's really a terrific tribute to what everybody does for these kids. She spoke at the World Congress Pediatric Cardiology, Cardiac Surgery in August of 2023 and brought her baby. And I think she's the third woman in the world with HLHS who's had a successful pregnancy and carried it. And the kid's toddling all around right now, and it's terrific. So to sum up, this is a major success from a historical perspective. I've had the privilege of living through most of it, but it still has one of the lowest survival rates of what we do. Morbidity has become expected. It should not be accepted. We have to do a better job with this. These questions will come up in your ORs, in our units, and there will be resistance to changing it because we're comfortable with what we do. I personally think we should abandon the Norwood in the newborn period. Should the Glen be eliminated? Is there a better way to do this and let the pulmonary arteries grow? I saw a debate recently that we should transplant all of them before they're 18. Interesting concept. I immediately said, why? But I don't know. I don't know if that's the right. So I'll close with this. For things to reveal themselves to us, we've got to be ready to abandon our views about them. As happened 40 years ago, it's going to happen now. Thanks very much for your time. I appreciate it. Did I stay on time?
Perfect.
Okay,
Couldn't have been any better. For me personally, that was an amazing talk, especially since I was with Tom Spray as well and got to operate and see what they could do firsthand. And I've also watched the field change so far. One question I have is a little bit about what happens when they do reach adulthood and the end of their Fontan life. We get a lot of those patients at Stanford who go to transplant, and they're very difficult transplants because of their acquired collaterals and things like that. What's your feeling about where those patients are now and where they're going?
Yeah, it's a terrific question. And of course, those adult congenitals were operated on at a time where we did things very differently than we do now. So the first disclaimer I'll say is I don't think the babies that are and the children going through it now will look the same. That's the first thing. I think they'll look better. Second thing is that what is being seen on the inpatient side is maybe 10%. The other 90% are pretty similar to the people that I showed you. And those of us who work in the inpatient side never get a chance to see that part and balance that feeling of dread that many of us have. So having said that, there was a lot of homograft used. The HLAs are terrible. It's very hard to transplant them. It's going to be a very tough group, and we're learning as we go. But I think on the optimistic side, it will be a better group of patients coming through.
Just the one, Nigel Cross. I used to work at Great Ormond Street. I loved the Norwood as a perfusionist because I always felt that I learned something each time we did one. Learned something else, just as a perfusionist. I've been retired a year. I didn't think I'd learn anything else. So thank you, because today I have.
Well, thank you. I've been retired for 4 months. How's it going?
I miss being a perfusionist because sorry about this, but it's a retirement thing. You know, tell me, what do you do? I'm a perfusionist, so there's lots of conversation that can go on from there. Tell me, what do you do? I'm retired. See ya.
I'm calling it preferment. I just get to do what I prefer, like come to this symposium.
Controversial comment and say that you got one thing wrong.
Yes.
And that's you described yourself as a pediatric cardiac intensivist. You mislabeled it. You are the pediatric cardiac intensivist. I think actually you've been very modest for the last 20 odd years. Everybody around the world in intensive care has followed your lead, which is one of the reasons why we wanted to get you here, because we want to learn from the best. So, I appreciate your modesty, but I think people really ought to know that actually your name will be up there and we will talk about you for many years to come as somebody who led that charge. So thank you very much for coming down.
Oh, you're far too kind. I am a rabid Philadelphia Eagles football fan. And this year, one of the expressions that's ahead is you can't be great without the greatness of others. And I have been at fantastic institutions. And the simulation session was just before this reminded me of that everybody teaches and everybody learns. And if we keep that attitude, it's always good.
I just asked if there was anything from the chat, and there is. I wanted her to be able to read a few things.
Sure.
Yeah, no questions, but there's a lot of comments in here saying, what a speaker, wow, a whole new field of CT surgery, absolutely incredible. So I think you made some fans in the chat.
Thank you.
Any other questions before I turn it back over to Richard? Yeah.
Just out of curiosity, with the prolonging the Norwood rather than going at 3 to 5 days, do you see any complications surgically or otherwise about prolonging the prostaglandin use for days and days and weeks?
Got it. So yeah, it's a great question. And there's a surgical myth about prostaglandin causing a lot of tissue edema. It's not the prostin that does it. It's the heart failure of a large open ductus. Once we put a band on and they're not in heart failure, we actually don't see that. The surgeons have told me the tissues are actually, I don't know the right word, sturdier, and that the kids, quote, I don't even know how to quantitate this, bounce off bypass. The heart is definitely better. Now the downside, there's always a downside, right? The downside is we're keeping the kids in the hospital an extra month. The bands can cause stenoses even if they're only there for a short period of time. And they do it, my colleagues do it extra pericardial, but they've had a little trouble with recurrent laryngeal nerve injury on the re-op. So it's always a trade-off, and it's important for us to identify both, but I think the heart really likes it. And I don't have any data from what my perfusionist has said. I want to see if I can find out about that as well.
One of the things we've taken to doing is stenting the duct open and not staying on PGE, and then putting the bands on. So a hybrid procedure that takes place in the cath lab, so that both of those, and so far we've had pretty good results from it.
Yeah, I think people are getting to the same endpoint in different ways, which is great, and we'll see which ones. Yeah, and the thing is, there was a great expression that I heard, business expression that said, don't find customers for your product, find products for your customers. One of the problems that we get into is we're a hybrid center, or we're a BTT center, and then everybody that comes into that center has the opt-out of that. I think there's 4 or 5 different ways to do this. Our job now is going to find out which patient would benefit best from a stent or a band or a neonatal Norwood or a transplant. That's going to be our next goal.
A follow-up question on a different path, though. Are you optimistic about the intraclude versus the external PA band? They're putting those.
Yep.
What are your thoughts on that?
Yeah, so
I know
for those who haven't seen them, it's basically a vascular plug with punched holes in it that get put in from the interventional catheter as integrate into the branch pulmonary arteries, and then a stent gets done. It's a so-called interventional stage 1. It's a tough learning curve. It's not the thing that everybody should be jumping into it. Physiologically, I love it. And like I was saying, I think, we'll see. The key now is sharing outcomes and sharing best practices. And we're able to do that with a lot of the databases now.
All right. Thank you very much. Any other questions we got? Okay. Thanks again.